Right. Prynhawn, good afternoon. So, as Anna said, my name is Charlie Doyle. I'm an Assistant Chief Constable with British Transport Police, and I'm the chair of the Suicide Prevention Strand for the National Police Chiefs Council. So I've held the portfolio for 6 years, and in that time I think I've learnt a lot about some of the challenges we, people in this room, collectively face. So I'm really delighted to be here at your conference. My thanks to Claire Cotter for the invitation and for the opportunity to address you this afternoon. I'm going to try and use technology and speak, which is never necessarily a happy bedfellow for me. There we go. So sadly, every year it's estimated that 700,000 people die across the world from suicide. In 2023, the Office of National Statistics reported that there were 6,069 deaths related to suicide registered in England and Wales, which equates to about 11.4 deaths of suicide per 100,000 population. That was the highest rate that we had seen since 1999. Indeed, in 2023, suicide rates in Wales were higher than in England. Disappointingly, both rates had increased from 2022. Now, this is a document that was published by Samaritans back in 22, and it basically breaks down the various costs, financial costs associated with suicide. So it's estimated that every single death by suicide in the UK costs an average of £1.46 million to the GDP. For children, it's double that. In Wales, this equates to about £500 million a year. Now, irrespective of the financial cost, every suicide is a tragedy, and in my opinion, many are preventable. The human cost is immeasurable, and every death has a far-reaching impact on families, friends, and the wider community. Now, indeed, academic research indicates that every suicide impacts at least 135 people. Now, often, those at risk of suicide may be known to health, police, or social care providers in advance of an adverse incident. Indeed, in many cases, there are groups within those groups that are at higher risk. This is particularly so for cases connected with mental health, self-harm, substance misuse, and domestic abuse, where risk increases with frequency and recency of contact. These can be complex cases, and maintaining effective cross-agency communication and data sharing presents a serious challenge to public services. Nevertheless, this presents us with a real opportunity to prevent an adverse incident occurring in the first place. Information sharing quickly and effectively, for me, remains the single most important issue for public services to resolve to effectively reduce suicide. Now, from the start of my role as the Police National Lead, it was my ambition to encourage police forces in particular to increase our situational awareness, improve our identification of risk groups, and establish tactics for early intervention. I wanted to refine our approach and shape how we engage with other response agencies and strategic partners to achieve this, that promoted a proactive and collaborative approach to information sharing for the purposes of suicide prevention, locally, regionally, and nationally. So in terms of our strategic ambition, in 2020 I drafted my thoughts on that, what that should look like, which was refreshed again in 2024, and it was based on these 7 themes. Today I'm going to talk to you about 2 of these themes in particular. Intelligence collection and surveillance systems, what we have been speaking about as near real-time suicide or suspected suicide surveillance, and improving the police referrals for bereavement support. So starting with intelligence collection, So real-time suspected suicide surveillance, or RTSS, is something many of you will be familiar with. I commend Public Health Wales for taking such a proactive approach to its adoption and its expansion, and I understand Dr. Ros Riley will be speaking about this after me and learning what it means in Wales. So given that your knowledge of RTSS is as good as it is, rather than explaining it in any great detail, I'll simply give you my insight as to how we started the journey. Before I do, I should remind you that data we collect relates to suspected suicides as assessed by police at scene, and is at that point intelligence, which is collected, collated, analysed and reported to inform risk. It informs our response to risk. It is not a determinant. Inquiry and determination to the cause of death is the purview of His Majesty's Coroner. So this is the journey we started on back in 2020. So pretty much ourselves and OHID were both thinking about this in sort of the different areas of work. So OHID were looking at it from a health perspective, predominantly in England, and we were looking at it from a police perspective. So we were each sort of ploughing our own furrow. Thankfully, we have now joined that ambition. So OHID are one of the partners that we actually share the RTSS data that we collect with. So the slide's a little busy, but it sort of gives you a sense of what that timeline looked like and the progress that we were making. And that journey continued then on to 2024. Now, historically, police and other services might wait 12 or 18 months for ONS data from the Office of National Statistics relating to suicide, as it was dependent on the outcome of coronial inquiry. And that process, as you know, can take some time, particularly in complex cases. However, in some environments, the profile of suicide events is frequent. So, for example, in British Transport Police, we attend over 330 suspected suicides each year on the railway. To reduce this number, we record, as you might imagine, a range of information to ensure that our actions and our mitigation work with Network Rail and train operators and inform our engagement with other strategic partners is effective. However, I was unaware of the suicide risk profile of any other force in the UK until ONS data was published. Bear in mind that the jurisdiction of the British Transport Police covers the entirety of the UK, so England, Scotland and Wales, and the 43 territorial forces that police England and Wales intersect with 10,000 kilometres of railway line and 2,500 railway stations. So effectively, I could never have a timely assessment of what risk might look like or what might present on the railway. Indeed, it was my view and that of Richard Mann, my former Detective Superintendent in Public Protection, that maintaining this approach meant that prospective risk, suicide patterns and trends would remain unseen, potentially until after a further adverse incident had occurred. Now, he and I had both been in policing a while, recognised that police forces across the UK attend every unexpected death and retrieve evidence, information and intelligence on behalf of coroners in England and Wales. As mentioned, there are 44 public-facing police forces in England and Wales, the 43 territorial police forces and British Transport Police. Each fulfills the role described for the coroner, and each has relevant information, often immediately after an unexpected death. At the time we started the journey, each force held its own data. There was no central assessment of police data. Now, I'm still a little unclear why it had taken our combined 70 years of police service to work that out, but we did recognise that fact, and having recognised it, we set to work about changing it and doing something about it. So that was to establish a method to pull national police data together and subject it to analysis. At times, as you might imagine, this was painful. In fact, on some days, it still is painful. Thankfully, Wales seem to have cracked it, and the four Welsh forces are very good in terms of submitting their data in a timely way. But what it did was enable us to gain a better understanding in near real time, which shaped our plans and activities accordingly. As you may know then, the real-time suspected suicide data, or near real-time suspected suicide data, is reported monthly. And we now have extended that sharing to a range of trusted partners, including health colleagues in Wales, to OHID, and more recently, over the last couple of 3 years, we've been sharing that data with some national work around domestic abuse, and that has pulled out some very interesting data, which is shortly to be published. In fact, it's just had ministerial sign-off, which indicates that the challenge with suicide and domestic abuse is much higher than we first thought. So, as I say, it's intended to provide situational awareness and enable us to develop our tactical plans. But it's also useful in terms of informing future strategic priorities. So the sorts of things we might be wanting to look at over the longer term. And I guess that is where support from governments, ministers, etc. is really important in terms of being able to crystallise that activity. Because at the moment, there's so many things we could do in this space. What the strategy enables us to do is to crystallise the activity across a range of partners and then focus it to make the biggest difference. So the effectiveness of the RTSS does rely on effective data analysis. It is contingent upon its proactive use. It is no good to just sort of leave it sitting in a corner. But it also requires forward-leaning partner collaboration. So people have to lean into trusting the data and then using it as best they can in the environment in which they work. So that's RTSS. Moving on to, moving on to bereavement support. So this is an area that's sort of close to my heart. And to set the scene, a few years ago I met with a lovely lady called Celia. And Celia was a lady who had lost her daughter to suicide on the railway. Her daughter had a long-standing history of complex needs, and at the time of her death was engaged across pretty much every public service. Celia described the terrible day when officers came to visit her address and informed her that her daughter had been killed on the railway, and the helplessness she felt in that moment and in the days and weeks that followed. She described how the attending officers had delivered this terrible news and the leaflets they had left on her coffee table. She then described the days and weeks that followed, unsupported and detached from her reality. She likened it to an explosion in her living room, the effects of which she was unable to address for some months. Now, she bore no malice to the officers, nor to the many services that had tried in vain to help her daughter. Yet she highlighted the absence of any meaningful support available to her at this most distressing time, and how the leaflets that officers had left remained untouched and unread months later. Now, as you can imagine, this was difficult to hear. These were my officers from my organisation. They had followed the policies and procedures I had approved. Yet in reality, they had done little more than convey the worst message any parent can receive, and had operated under the misguided belief that providing information was providing support. Consequently, the next day, I commissioned a review of our approach. We changed our policies, we changed our procedures, we retrained our officers, and we updated all of the information we used to support survivors of suicide. Celia was very helpful in terms of shaping what those things looked like to give us a more fulsome approach to bereavement support and referral. Every survivor now receives a call within 24 hours of an adverse incident occurring. So in addition to the initial message being passed, there is then immediate follow-up from us as an organisation, and as I will tell you about in terms of onward referral. So also what struck me was, despite the many fantastic providers, national services and agencies, finding local professional support was not always easy. And in many cases, self-help groups had organically grown following their own personal tragedy. I was keen to remove this burden from grieving families. My meeting with Celia prompted another epiphany. Historically, we had sought consent to refer the bereaved and support services. Given that what she describes, I sort of formed the view, how could anybody in that position really give informed consent? Moreover, who would we refer them to? Now, in any event, those that experience suicide of a loved one are at a greater risk of suicide themselves. Consequently, I asked my own information management team to explore what options I had in terms of information sharing. Now, upon their recommendation, I decided that my organisation, British Transport Police, would adopt a presumption to refer the bereaved through suicide using their personal data under the public task duty. This effectively enables us to process personal data if it's necessary to perform a task that is in the public interest or for the official function that we conduct, and the task and function itself has a clear basis in law. Now, I can't think of anything more important than saving a life. So for me, it was a pretty easy decision to make. Furthermore, to ensure timely support was available at BTP, we introduced a single provider. Now, in our case, that's an organisation called Amparo, and they centrally coordinate our bereavement referrals on our behalf with local services. So I'm pleased to say that a number of forces have followed suit and now use the public task duty to refer people for support rather than relying on consent. Now, of course, people can opt out, but in my experience, they are simply grateful that we have taken that responsibility from them and directed support to them at the most difficult times in their lives. Now, you'll be familiar with the data for Wales, and I would highlight the fantastic work that is already underway, and that's just been reaffirmed from what I've heard today. I absolutely commend the tireless work that has been undertaken to develop the strategy and the drive and determination of the Welsh Government to bring this to life. I'd also like to commend the work that the National Bereavement Support Steering Group, chaired by Dr. Idris Baker, is doing. And if we get, I don't know if he's here, but if we get a chance to sort of catch up, compare notes, that would be fantastic. I'd also like to thank the Minister, obviously who spoke this morning. The commitment to invest £3 million in Wales to support 18 third sector organisations around bereavement support is truly remarkable, and I think if others could follow suit, I think that would be most welcome by those organisations. So I'll close by saying how proud I am of the progress we've made and for the fantastic efforts of the many great people that I work with, for all those dedicated people across public services, private industry and charitable organisations that are committed to reducing suicide. Thank you for giving me the opportunity to speak to you today. Jochen Var, thank you very much.